Good afternoon, ladies. I hope you prepared a nice lunch for yourself. My name is Dr. Frank Bonura. I'm a gynecologist. I practice in Smithtown, and I am Director of Menopausal Health at St. Catherine of Siena Medical Center. Today is the sixth lecture on a women's healthcare issue brought to you from St. Catherine of Siena Menopausal Health Program. Next slide. Our topic today is on vaginitis. 80% of you will have an episode of vaginitis one time in your lifetime, and 50% of you will have more than one episode of vaginitis in your lifetime. The three most common types of vaginitis are bacterial vaginosis. The second most common would be Candida albicans or yeast vaginitis. And the third kind would be atrophic vaginitis in menopause. And we see atrophic vaginitis in anywhere from 75 to 90% of elderly women in menopause. This is a picture of a normal, healthy vagina in women in the reproductive stage of their life between ages 14 and 49. The color of the vagina is pink. The lining is very, very thick. There's an increased blood supply. And if we check the pH, the acidity, the vagina has an acidic pH. Now, the reason for all of this is that in a healthy woman in the reproductive stage of their life, they're making estrogen, and estrogen increases the blood supply. Estrogen thickens the lining of the vagina. Estrogen increases the collagen and the elastic fibers in the vagina, and estrogen makes the lining cells pick up a pre-sugar called glycogen. Now, the vagina in the reproductive stages of your life is not sterile. 95% of the bacteria called lactobacilli are good bacteria. What they do is the following. Estrogen that you produce from your ovaries makes a pre-sugar attach or go into the cells of your vagina. And when those cells are shed every day, the lactobacilli pick that up and make lactic acid and hydrogen peroxide, which kills the bad bacteria. It stops the 5% of bad bacteria that you're in your vagina from colonizing and growing. So the good bacteria, 95% of them in the vagina are the lactobacilli, and they make an acidic barrier, not only from the bad bacteria that are normally present in the vagina, but they stop invaders, bacteria from the anal area and STDs. They stop gonorrhea, they stop trichomonas, and they can even stop HIV. So the acidic barrier is very, very important. Next slide. Women who come in with a history of vaginitis, and some of you that have these symptoms, you go to your gynecologist and you complain of burning outside the vagina, burning inside the vagina, or both. And we always check with symptoms. Is it inside, outside, or both? Is it every day or only during the time of your periods? We ask you the type of discharge that you have. What color is it? How is the consistency? Is the consistency of the discharge thin or very thick? Is it more like cottage cheese? Does it have an odor? We also check to see what medical problems you have, because people who have diabetes have a higher incidence of yeast infections in the vagina. We also check to see what drugs you're on. People who are on antibiotics or birth control pills have a high incidence of yeast vaginitis. We also check what your sexual practices are. If you do orogenital sex, do you do anal sex? Do you do anal sex before you have vaginal sex? Do you have an IUD? Are you on birth control pills, or are you using a diaphragm? And lastly, what we do is we do a pelvic exam. We examine your external genitalia to look for redness or discharge, and then we put a speculum in your vagina. We inspect the walls of your vagina to see if they're inflamed. We always do a pH. The normal pH is 3.5 to 4.5. That means it's acidic. That's a barrier, the acidic barrier. And then we take a sample of your discharge and we do this to see if there's a fishy or foul odor to it. If not, we add a drop of potassium hydroxide, and if it releases a fishy odor or rotten egg odor, we know that it might be bacterial vaginosis. And then we do a smear, and sometimes we do a culture. Next slide. This would be a slide in a woman. Those dark pink cells up on the top with little dots in them would be called clue cells. We see this quite frequently in women who have bacterial vaginosis. Those long squiggly things, green things, are yeast spores. If we saw a lot of them, we would think you may have a yeast infection. Next slide. Bacterial vaginosis. Bacterial vaginosis is the most common type of vaginitis that we see in gynecological practice. 21 million women have it every year. That would be about 30% of all the women in America, and 50% of these women always get a recurrence. And the reason why bacterial vaginosis occurs, there's no lactobacilli in the vagina for one reason or another, and there's no acid. They've lost the acidic barrier in the vagina. Next slide. This is what we see when we examine you. That metal object is a speculum. When we look in the vagina, the walls of the vagina and cervix are inflamed, and there's this thin, whitish, greenish or yellowish discharge that clings to the walls of the vagina. If we take a pH, it's above the acidic, it's more than 4.5. There's no acid in the vagina, and the discharge would have an odor to it. Next slide. Now, what are the risk factors for bacterial vaginosis? Well, we know it's sexually associated. So if you have multiple male sexual partners, you have an increased risk of bacterial vaginosis. If you douche, years ago, all women were using douches. Douching decreases your population of lactobacilli. If you eat a diet high in sugar, in menopause, we see it because there's lack of estrogen in the vagina, there's lack of the acidic barrier, and they develop bacterial vaginosis. And again, we see it in women who have sex with women, bacterial vaginosis, and we see it in women who have anal sex followed by vaginal sex. Next slide. How do we make the diagnosis? We have to have 3 out of 4 of the following. 1, the pH that we check in our office is more than 4.5. You have this whitish grayish discharge that clings to the walls of your vagina. It has a fishy odor, either spontaneously when we do this to the speculum, or if we add a drop of potassium hydroxide. And if we do a smear, we see those cells. Show the next slide, please. And these are the cells up top, these deeply pink cells with all the little dots in. They are called clue cells. And if we have 3 of those 4, our diagnosis is bacterial vaginosis. Next slide. Now, how do we treat bacterial vaginosis? Well, it's pretty simple. The CDC tells us to use either Metrogel vaginal cream. It's an antibiotic cream. You would use 1 applicator full at night for 5 nights. Or we can give you a pill to take, Flagyl, 500 milligrams. It's 2 pills a day for 7 days. But remember, ladies, if you take alcohol, you cannot take alcohol with Flagyl because it'll make you dizzy and you might faint from the alcohol. Or you can use clindamycin vaginal cream and applicator full every night at bedtime for 7 nights. And now we have something new. It's called Solosec Granule. It's a little package. It's 1 dose. You sprinkle it on Jello or applesauce. You don't chew it. Or you can even put it in yogurt. You swallow it. You do not add it to water. Next slide. The next most common type of vaginitis is Candida or yeast vaginitis, and the organism, the yeast that causes it, 90% of the times is Candida albicans. 75% of you will have one episode during your lifetime, and 50% of you will have more than one episode of yeast vaginitis. The symptoms are, next slide, irritation on the outside of your vagina. This cottage cheese discharge that you see, itchiness and burning inside or outside. The pH can be normal, and when we check the odor, there is no odor to this discharge. Next slide. And just shows a smear you would see of overabundance of those green squiggly things in the middle of the slide. And we would make a diagnosis that those are yeast hypha, and we make a diagnosis that you have a manilial or yeast infection of the vagina. Next slide. Now, what are the risks for Candida or yeast vaginitis? The major risk is diabetes, because diabetics spill sugar in their urine, which goes into the vagina too. Antibiotic use, especially the broad spectrum antibiotic use, increases your yeast of a yeast vaginitis. Menopause increases your risk of a yeast infection because of decreased estrogen. Oral genital sex increases your risk. IUDs increase your risk, and diaphragm uses increase your risk. Next slide.
Well, at least I got it.
Can you hear?
Yeah.
How do we treat yeast vaginitis? It's relatively easy. You can go buy over the counter without even calling your doctor, or the doctor can advise you to use Monostat cream or suppositories for 7 days. Or we can order Terazol 7. It would be 1 applicator full every night at bedtime for 7 nights. Or we can use a pill, diflucan. 1 pill, 1 dose. Or we can use nystatin vaginal tablets for 7 days. We also tell you to limit the sugar in your diet, because we don't want you spilling sugar while you're taking medications, or limit your sugar all the time. Next slide. How about atrophic vaginitis? I told you that I am director of menopausal health, and I see a lot of menopausal patients in my practice. And what I tell the ladies who are out there who are menopausal, and you're menopausal when you haven't had a period for at least a year, the average age is 51, your hot flashes and night sweats get better, but the genitourinary syndrome of menopause, that is changes, anatomical changes in your vulva, your vagina, your bladder, and the tube you pass your urine from your urethra, change from lack of estrogen. Everything gets thinner, the vagina barrel closes, the layer of the vagina becomes very thin, you have no pH in the vagina, bacterial vaginosis grows, and so does yeast infections. Next slide. And what we can see in a menopausal vagina, when we put that metal instrument in, instead of the vagina being pink, it's white, It's very thin. It may have punched out areas or areas of bleeding. You may have a discharge that's either clear or greenish and blood tinged. And that's what atrophic vaginitis is. Next slide. And how we treat atrophic vaginitis in our offices, first we would offer, if there's no bacterial vaginosis or yeast infections, and we can tell that by doing a smear and looking at your smear, we would use a vaginal moisturizer that lowers your vaginal pH and makes it acidic. And the one that we use in our office is Luvina. You can buy it in Stop and Shop or Costco or whatever place that you shop in. And you would use a half an applicator full every other evening. But remember, moisturizers do not restore the anatomy that you've lost from not using estrogen. Or if the moisturizer doesn't work, we use vaginal estrogen in a cream, a tablet, or a ring. And it's relatively safe to use. There's relatively almost no absorption in the general circulation. And now we have something new called intrarosa, which is dehydroepiandrosterone that we use for atrophic vaginitis. Next slide. Recurrent vaginitis. Recurrent vaginitis means you've had 3 or more episodes in 1 year. And we see a lot of recurrent vaginitis in people who have bacterial vaginosis, in people who have yeast infections, and in people who have atrophic vaginitis. Next slide. Now, how do we treat recurrent bacterial vaginitis? I had said that 50% of you that have bacterial vaginosis will have another episode. What we do is we first treat the bacterial vaginosis, the episode, and then we put you on maintenance therapy. The maintenance therapy can be the vaginal gel twice a week for 6 months, or we can give you 2 grams of Flagyl pill by mouth and diflucane 1 time a month for 6 months, because many times bacterial vaginosis is associated with a yeast infection. And some people use boric acid vaginal capsules. That's made by a compound pharmacy. If you took it by mouth, it would be lethal. And one of our patients took it vaginally and she had a burn from it. So I don't use boric acid capsules in my practice. We also recommend, since recurrent bacterial vaginosis is sexually associated, have your male partner use a condom and try to acidify, if you're menopausal, your vagina with lactic acid. If you can't acidify it with lactic acid, what we do is we use vaginal estrogen. Next slide. Now, recurrent yeast vaginitis is a little different. I had said that 95% of the yeasts that cause a vaginitis are Candida albicans. In 5 to 10%, it's a different variety that doesn't respond to monostat or terazole or diflucane. And that the one that we see is Candida glabrata. So a culture is very important to do if you have recurrent yeast infection. No, but if it's not Candida glabrata, we treat you with vaginal therapy, monostat or terazole for 7 days, or give you 3 doses of diflucan when you have the infection, the yeast vaginitis. You would take 1 dose every 72 hours. And then after that, you would take a dose monthly for 6 months. Excuse me, weekly for 6 months. If you grow out Candida glabrata, in our practice, we use nystatin vaginal suppositories for 14 days. But you could use boric acid vaginal capsules, but be careful. I said one of our patients got a burn from it. Stop. The takeaway points from this talk are: vaginitis, if you have symptoms of vaginitis, you should call your gynecologist and they should treat you adequately. If you have recurrent vaginitis, you should be put on suppressive therapy. If you're menopausal and your doctor tells you that your vaginal pH is low or high, excuse me, if your vaginal pH is more than 4.5, then you should be on a moisturizer that lowers your vaginal pH, because if your pH is very high, then you put yourself at risk not only for vaginitis, but if rectal bacteria get in your vagina, they can go up the tube that you pass your urine from, and you can develop recurrent urinary tract infections. Does anyone have any questions? I need a favor from you ladies that are out there. I need you to visit my Facebook page, Frank Bonura, MD, or my webpage, and make suggestions on what programs you'd like to hear from our program, our menopausal health program. Also, if you have any questions, you can post them on my Facebook page and I'll answer them for you. I think that's a wrap. We say in Italian, buon appetito, enjoy your lunch. And that's it.
Thank you, ladies. If you'd like to unmute yourself and ask a question, Dr. Bonura is here for a couple more minutes, or you can type something into the chat, or as he mentioned, follow up on his Facebook page and his website. Thank you for joining us today.